Hello, everyone, and a warm welcome to SDN Community Voices. This is episode 55. I'm so glad that you are here. My name is Genevieve Brechel. I'm a senior service and experience designer, CX researcher, and workshop facilitator based in Berlin, and an SDN ambassador and your host for today. And for the ones who haven't been to Community Voices, it is a relaxed bi-weekly live touchpoint for you, the SDN audience. And each episode features a different voice from the service design community, always story-driven, informal, no slides, no pressure, just real experiences from the service design community and its practitioners. Today, we are looking at service design applied to hospitals. There's, of course, the front stage where patients experience the care. And then there's the backstage where the work happens that patients never see. And I'm sure most of us have been a patient at some point. But what you experience, what you as a patient do not experience, is actually behind the stage, hides a huge, mostly invisible world. And better design there means better care for you, but also better work for the people who care for you as a patient. And we will all talk about this with Dr. Scott Marin. Welcome.
Thank you.
He's an emergency physician and principal consultant at Northern Insights Innovation. This is his own healthcare first design consultancy. And what I love is that he is not a designer brought into healthcare, but he's a clinician doing the design work from inside it. He practices across Canada, from an academic health center to a remote hospital in the Arctic, and has worked in more than 20 hospitals over his career. And design runs through his family. His sibling is an industrial designer, and his partner is a designer too. So again, welcome. I'm looking so much forward to this conversation.
Thank you for the introduction.
Would you like to add a few more words about yourself?
I think I think I should give some context for like how I came to this kind of thing. So I initially worked as an emergency physician in a variety of remote locations in Canada. And through my career, I eventually ended up in a role of administration as chief of emergency medicine in Nunavut. And during my time there, it became more clear to me that certain design principles would be applicable to healthcare service delivery. And that's kind of what started me on this path towards using service design principles within the healthcare environment.
Yeah, and that is really helpful to give this context. You mentioned Nunavut. Where is this? Maybe you also give us
Nunavut.
a little bit of a map orientation.
Sure. So Nunavut is one of the Arctic territories in Canada. So Canada's obviously, it's the second largest country in the world by land area. It's absolutely massive. And a lot of it is inhabited by very sparse population centers. And we use the term the tyranny of distance for delivering care in those areas. Nunavut is one of those areas, and the area that I particularly was working out of was Iqaluit, and it's on Baffin Island, which I say is off the coast of Greenland, but it's an island twice the size of the UK.
So a big island.
Definitely. It's a big island, and it has a small regional center, a medical center with surgical services, emergency services, critical care, that kind of thing.
All right. I'm not sure if everyone experiences, but sometimes you're lacking. So maybe you can also drop in the comments if you see some issues with the connection, but also feel free to drop some questions that you have for Scott, because we will address them by the end of the session too. And I think this is also a good opportunity to give like a little roadmap what we will experience Okay, now you're back. Very
I'm back.
nice.
So
Um,
2,100 kilometers is where I left off
yeah.
to the tertiary care
Okay.
center.
Thank you for finishing up this detail. I was just about to give a little bit of a roadmap about what we will hear from you today. So you already touched a little bit how you actually got into design. So that will be one point that we talk a little bit more about it. Then the reality inside hospitals, 3 projects that you will present, and also a quick fire round as well. And in the end, questions from the audience. So again, you, the audience, if you have any questions, drop them. Also, please let us know where you're from. So Scott is from Canada and I'm from Berlin, Germany. So feel free to share this detail too. All right. I hope the connection is now strong enough. So let's
Yeah.
continue. And you mentioned already that you started getting into this topic, service design or using design methods at your work at Novo Boot. But you also mentioned to me in our conversation that you also got influenced by people that are close to you, your sister and also your partner who are
Definitely.
designers too. Could you also share a little bit about this as well, and maybe maybe also a moment where it hit you, oh, I'm actually doing design now?
So my sister is a Harvard-trained industrial designer. One of my best friends from medical school was an industrial designer before going to medical school. I have 2 or 3 other friends who are UX designers, someone else who's an industrial designer.
Mm-hmm.
So I've been in an indirect design community without really having formally trained in that area. My partner, who is also Berlin based, she was a UX design manager for tech companies. And in 2021, I had been kind of working on projects, administrative projects, looking at how we did service delivery. And there came kind of a time where we recognized, like, oh, the types of things that we're talking about with user issues, patient issues, delivery issues, these are overlaps between both areas. But as we'll kind of get to after, the way these processes are typically done in a healthcare environment are more ad hoc and at times haphazard than formally done in a design environment.
Mm-hmm.
I think what really kicked off thinking of things from a design mindset was when I had been inspired to create a dashboard for medical records software called Meditech to allow physicians access to the outcomes of their patients. Because in an emergency department, you often only see the doctor once. And the doctor never sees you again, and they have no clue what happened to you, whether they made good decisions or not. So feedback is a real issue. So I decided to head up the design of a system called EPOIS, which is an emergency physician outcome alert system, to give this access to alerted feedback on I hate the word performance metrics. Outcome metrics, I think, is better for physicians. So in that particular design process, with a little bit of hand holding, I quite formally mapped out what the end dashboard / product, if you wanted to call it that, is going to look like. And that was really kind of the beginning of like shifting my thinking towards something that was more design focused.
Yeah, interesting. And how did it actually occur that they would ask you to do that?
They didn't.
I mean, it's not like they didn't. It was just an initiative from your side?
So yeah, there was 2 things that went on there. One was I personally, as an emergency physician, lacked feedback on what happened to patients. Like, you can do a little bit of tracking, but it's hard to know. Sometimes you don't think anything's going to come of a particular patient scenario, and you're never alerted to the result. So I had my own desire for a better way to track this.
Okay,
And
you had a pain point, basically.
yeah, I had a pain point that I wanted a solution to. And I didn't invent this idea of having an outcomes alert system. I simply developed well, I should say designed, somebody else developed the dashboard. I developed that idea for our particular context and software, but there was a group in the United States, I think based out of the University of Maryland, that had already done this type of project for another electronic medical record system called Epic. So after being inspired by that, recognizing that we weren't going to purchase this software, we were going to use the software we had, it was more an issue of like, how do I get developers to help me design this and apply it to my own work environment?
And okay, that's interesting. I guess, and maybe this is also an influence through your environment. You see that they're always looking to find solutions, and you also were frustrated that there's no solution right away for you, and you become active and about it. But the question is also, are you basically a unicorn within the hospital environment, or how does actually the reality in hospitals look at the moment?
So that really depends on the hospital. The reality is service designers as a position is not a common thing in most hospitals. But what I will say is that hospitals of innovation, we're talking Charité in Berlin, Tel Aviv University in Tel Aviv, Mayo Clinic in the United States, University Health Network in Toronto. Those kinds of hospitals do have more service design oriented people working for them. But outside of the context of really healthcare leading organizations, it's not a common thing. And certainly design thinking, healthcare administration is a common thing for people to be trained in. But the idea of coming at healthcare administration from a design perspective is more unique.
So, and when you say from a design perspective, is your understanding, someone actually looks at the process and looks at the gaps and what is missing and what needs improvement? Do you mean this from looking at the design perspective? Because I can imagine people from administration do have maybe an idea of a process, of a workflow, but they maybe never question that.
They absolutely do. What I find is that there is some nuance in how a designer looks at service design issues and how a clinician looks at them. I think also when clinicians are looking at them, and this includes myself in this problem, first there's a bias because we're clinicians, we're not patients. So patient participation is increasingly being recognized as an important part of the design process. I think when you have an outside designer, you have somebody who's going to look more globally at who the users are, how user research is conducted, because user research is its own field of study, and it's its own skill set. And I think that is something that is not something inherent in healthcare administration, to think of things of how you conduct user research, for instance. And we saw that at the UX Healthcare conference in Berlin when we were talking last year, with some of the cases coming out of, say, like the NHS, where they had specifically hired designers to assist with delivery of particular healthcare products.
Yeah. So when you say NHS, you mean the healthcare organization in UK, right?
In the UK, yes. In the UK.
And just for context, Charité is one of the biggest university hospitals in Europe, right? And you also mentioned one or two who are really big, and they consider like service design or design processes. But you would say it's certainly
to the extent that they will hire people specifically for that. Okay. That's where I'm really trying to emphasize that there are hospitals globally, perhaps only a handful of them, that do hire service designers for these processes. But service design is done at every hospital because healthcare is a service at the end of the day.
Yes, but then it's the question how it's approached, basically. So in terms of the maturity and if they really consider the view of the patients. So would you give me here an example what it takes basically for an idea, like you mentioned with the dashboard, to become reality, and what kind of people you need for this. Because as mentioned, you said not every hospital has a service designer or like someone who thinks more like from the patient user perspective.
Mhm.
So what does it take to implement new ideas, new processes to become reality in the end?
I mean, the reality is it takes
Yeah.
leadership. It takes internal leadership at the organization. That's one thing. And the other thing that I've really kind of come to appreciate is not only leadership, because leadership is one thing. You can convince someone who is a hospital leader that you have a good idea. But the second thing is to look at it from a perspective of who holds the purse strings, who actually can make financial decisions in an institution. And that you need them on board as well. One way I think that if there are service designers who are wondering like how can we break in more into the hospital environment, that I would consider is the idea of doing talks, of showing up at healthcare events and just making an awareness of design as a service design as a discipline is something that I would suggest. If you can get an awareness about projects to the right people, you really only have to convince the right purse string holder that you're offering something of value, and it's done.
Yeah.
You need internal champions, of course, but a champion is, in my experience, as a champion as well, this is not a critique of anybody else, they're useless if they don't have meaningful leadership that's going to respond to what they're trying to champion.
Yeah, I mean, this is a good point. And I think not only in healthcare or in hospitals, you experience that you need to convince leadership to get the buy-in. But obviously, it also takes a motivated person, as you mentioned, a champion, to move forward with this as well. Just quick follow-up on the leadership part. Would you say that people who are in the administration are basically the leadership of this whole
In a
institution?
hospital, yeah, in a hospital, the administration is the overarching leadership. Of course, there's leadership in the operating room, and that's very very different from
Yeah.
leadership in administration. I think that's part of why I was able to execute a few of these projects. Some of them I was in leadership,
Yeah.
so I was able to direct them because I was one of the leadership. And outside of that, I've been fortunate to have support from leadership for consulting consulting projects as well. So those are kind of the nuances to trying to do this kind of thing in a hospital environment.
Yeah, all right. Thank you for sharing that. Before we move forward to the project actually that you worked on, and very interesting one in
Yeah.
the area of transfusion, I would like to just highlight that we have people here from Taiwan and India, and also even from Brazil. I'm so happy to welcome all those people in our live stream. And now let's move forward. And by the way, if you have questions, don't hesitate, drop them in the chat, and we will try to address them by the end of this conversation. But now to the first project, because you mentioned you had this opportunity to innovate in a hospital. Your first one was the dashboard, but then you also started to work as a consultant and work in different hospitals for a particular project. And one of those projects was the massive transfusion protocol. Could you tell us a little bit more about this?
Yeah, so this first project was actually began when I was still in my leadership role. The massive transfusion protocol, basically, I think first let's talk about like what is a massive transfusion. So a massive transfusion is a transfusion of many units of blood for a patient who is imminently bleeding to death. And it's a complicated thing to deliver because first, it can happen in different parts of the hospital. It can happen in the emergency room. It can happen in the operating room. It can happen really at any location. Second, when a massive transfusion is ordered, a lot of blood needs to be dispensed from the hospital blood bank where blood is stored. And there are a lot of safety precautions that have to be followed when delivering blood. including issues with matching, issues with safety of the blood itself, storage, etc. So all of this has to come together extremely quickly and in a very coordinated manner. So to that end, most hospitals seek to have a protocol in advance prepared for how they're going to deliver this blood. So in this case, I was asked to work on developing the massive transfusion protocol for a small hospital. And I don't know if you wanted to ask more questions, perhaps.
I mean, I can.
This is kind of the overarching part.
I mean, so I think this is really interesting. I mean, even myself, watching Emergency Room, there's a TV show called like this, to see, to know, okay, there's like a step how blood is transfused. And of course, for me to survive as a patient, but what does it actually take for all the caretakers, the doctors, the nurses, and the lab people to coordinate? What are like the highlights of your discovery? Because I can imagine that you maybe started like to analyze the steps and really understand what each step meant, or how did you approach it?
Yeah, so it started with user, well, let's say stakeholder interviews, because we didn't interview any patients in the process of this one. The patient has, unlike a lot of service design oriented like tech products, the user actually doesn't have a lot of actions to perform in this type of situation. They either continue to bleed or stop bleeding. That's just kind of the arch point.
Yeah, and the doctor basically takes a lot of decisions here, right?
Yeah, the doctor does most of the deciding. So I built out a service blueprint that kind of looked at the doctors, the nurses, the transport workers, the laboratory technicians, and then the far back end, which is kind of like the tech support side of things, of how things are digitally tracked. So we mapped out an entire service blueprint for how we would deliver this blood, how many boxes of blood would come at what time, what type of blood would be in there as a default, what would the second box would look like, how they would be sent sequentially from the lab as the lab prepares more and more units, how the tags, for instance, would end up, the tags that come off the blood units would end up back at the lab. What other types of blood products would be necessary besides simply packed red cells, things like fibrinogen concentrate, where that would come from, how the staff would do that. So we made out this entire we made out this entire blueprint to look at how we would deliver the blood. But I think the more important part, because this is a typical type of process, well, not typical in the service blueprint, but this type of protocol would be made without a design mentality. I think what was different was we iterated the protocol before implementing it. And traditionally, a lot of hospitals would just take senior clinicians, say, how do you think we should do this? Write it down, put it in a policy, and put the policy online, and it never got tested. And increasingly in the last 10 years, particularly with this term coined translational simulation, we've been iterating policies before they came out. And that's what we did in this case. We iterated the policy, the protocol, by using a fictional patient scenario and having staff act out the roles that they would fill within that protocol, and see what were the outcomes there in terms of like what could we improve.
Yeah, that is interesting that you use this technique, and I would like to know, all right, you did your stakeholder interviews, probably leadership, doctors, and lab people, and so on.
Lab staff.
And then you mapped out based on that, like a workflow, basically, And then from there, you designed the simulation. What were like the biggest insights from the simulation? And did you also experience any obstacles during this process?
In terms of the insights, we came up with a few things. First, the lab needed to know the sex of the patient immediately, because that makes a difference on whether the first unit is O negative or O positive.
Okay. Mm-hmm.
So we do have patients come in that we don't know their name, so we don't have a name associated with them in the computer. So they get kind of like a Jane or John Doe type of name, temporary placeholder. So that was not integrated into the protocol, so that was an oversight. We additionally noticed that the first unit of blood was delayed because the person who had been identified as the runner or the transport person for the first few units, the first prepared box, was coming from another unit in the hospital. So we made the decision that whatever unit the massive transfusion is occurring on, the transport worker should be coming from that unit and not from a distant location. We also noticed that the lab needed to know when the protocol was stopped. So that hadn't been formalized in there. This also comes from, probably in part from my own physician perspective. I said stop. I didn't. Who did that get communicated to? It got communicated to the nurse, but if nobody else was alerting the lab, they were busy still preparing subsequent boxes. And we also noticed that our staff had some difficulty reconstituting the fibrinogen concentrates. So in that case, what was more an issue wasn't the protocol, but educational issue that was identified that had to be kind of worked through. It wasn't really related directly to the protocol.
What do you mean with educational? What do you mean with this?
Meaning that it was more that they weren't familiar with how to reconstitute the product quickly. They were more kind of, taking out the product monograph and checking to see how that was done, and that's not really what we want in these situations. So we identified the need to work more diligently with staff to ensure that this was a task that they were comfortable doing in a crisis scenario. And that's what comes out of a lot of translational simulations is you find out insights that you weren't necessarily expecting to find. And that's the value of doing this.
Yeah.
If you knew what the insights were, what would be the point of iterating it or doing this type of simulation?
Yeah, did you meet any obstacles to say, hey, let's do a simulation? Because I can imagine this is not something that you do that often.
Well, healthcare simulation is pretty normal for training. So that's not unique. Most staff will be very familiar with having done some degree of simulation during their career. What's more unique is doing it in your own work environment.
Yeah.
And the other thing is being videotaped for it. So, or the video part is the part that I thought would have more opposition. For another project I worked on that we may discuss later, I thought like that was going to be the challenge, was would people be willing to participate voluntarily, because it was like, would they volunteer to have their own job performance recorded? And they did. It wasn't an issue. I think there needs to be a good kind of informed consent about why we're doing this, what the purpose is, and that people know that we're not here to like impact employee evaluations or something like that. We're there to try to make their work easier. And with that in mind, I haven't had opposition to it.
Yeah, I mean, this is a good point, because when you do user research or a simulation like this, you need to also make the people feel comfortable being basically in this testing environment. And I also would always say, hey, no one is judging you, right? And this is not a performance. And I think this is very important. And then I assume that then afterwards you analyzed the videos right? Took
Yeah.
notes of it and then delivered basically this updated blueprint. Were there any gaps where you think, oh, this should have been covered in the blueprint as well?
Well, the ones I've mentioned already, but besides that, no.
You mean like with the tagging?
So, for instance, the
Yeah.
tagging was missing, the endpoint was missing, the immediate identification of patient sex when the massive transfusion was initiated. Those were not in it, and they were then added, and now they've been successfully using this without significant hiccups.
I would like also already, because someone on LinkedIn already posted the questions a few days ago, and it actually addresses the translational simulation part. And how is translational simulation different from the prototyping or walkthroughs designers usually do?
How is it different from, say that again?
From the prototyping or walkthroughs designers usually do, if you have some familiarity on it.
I think, yeah, I think there's enormous overlap. In fact, translational simulation is used in prototyping. So, for instance, I'm in Ottawa today in Canada. They're building a massive, brand new academic health center nearby. There is they've partnered with the University of Ottawa's simulation group, and they've built out in a warehouse here 12 different types of patient rooms as prototypes. So in that sense, it's the same. They're building a prototype. The difference is they're not only using the prototype for a walkthrough or to get feedback, they're then actually doing simulations where they're trying to do actual work in the prototyped environment. So I'd say there's overlap between those two things. In some ways, it's the way that prototyping can be done in a healthcare environment. So it's not simply walking through the prototyped environment, it's also working through the prototyped environment.
All right, thank you. Given now the time that we have left, I would like to go to the second project that you worked on. And thank you so much also to the audience sharing their questions already in the chat. So the second one is the cardiac CT. So some of us have an idea what is in CT and so on. So maybe you can give us a little intro to this project and what you actually have done there.
So the CT scanner is the donut of truth, is its nickname.
What did you say?
The nickname for a CT scanner is the donut of truth.
Oh, wow.
The giant machine that you go in. It delivers radiation. It can scan quite quickly. It's used for particular types of problems that we're looking for. And unlike an MRI takes a much longer time to do a scan. It looks at different problems, and it doesn't use radiation, it uses magnets. So the problem at the time, this is a couple of years ago now, they have a new scanner, so this whole project now wouldn't be necessary. But at the time, with the technology that they had, the cardiac CT could only scan hearts at low radiation doses if the patient's heart rate was less than 60 beats per minute. So
this is low? What is it, low or?
This is low, yeah. 60 to 100 is a normal heart rate, and most people, unless you're an athlete, don't have heart rates even in the low 60s. So this is less than 60, so a heart rate in the 50s. So this is achieved typically through giving medication to lower the heart rate. But it also needs to be done safely, and these patients come in as outpatients, so they're booked in. The idea is we're screening them to find out if they need to have an angiogram, and the cardiac radiologists who are reading these scans remotely, they weren't happy with the non-diagnostic rate. So what that means is there were too many scans that they just couldn't read. They couldn't say whether they were positive, that they had heart disease or that they didn't have heart disease, coronary artery disease to be specific. And part of that was scanning patients whose heart rate was too fast and not canceling enough scans. So scanning patients despite the fact that they had high heart rates, which leads to a nearly 10-fold radiation dose. So they weren't happy with this. So what I was tasked to do was work with the team there to develop a process, a service delivery process, whereby we would improve both of these metrics, the non-diagnostic rate and the unacceptably low cancellation rate. I know that sounds weird, but actually it's like there's a certain number that should be canceled and a different test should be used for investigating them. So those were the two kind of KPIs we needed to work with. So what we ended up developing was a pre-procedural. The day before, patients would come. They would have an educational session about not drinking caffeine, not smoking cigarettes, because these things make it more difficult for us to lower their heart rate. We developed a formalized advanced medical directive so that the nurses working with the radiation technologists or radiology technologists could administer heart rate lowering medication safely in the radiology suite without the physicians immediately present. And we were able to see substantial change in the non-diagnostic rate. And additionally, and this is one of the problems of doing things as a consultant, I left before they had statistical significance for the improvement in the non-diagnostic rate. But what I had gotten as anecdotal feedback from their cardiac radiologists was there had been an improvement in the ability of them to be able to read the scans. So we saw, we were able to improve both KPIs through the delivery of a formalized system.
So, okay, and that is really great news that you improved that part. So basically in the end, through this process that I assume that you used stakeholder interviews, also understanding the obstacles of patients and then the nurses who have to take care of the process as well. Then you also did like a simulation, is that correct?
In this case, we didn't do a simulation.
So you just did like, okay, this is what we want to do, and we just live test.
This was more your service design pathway kind of thing. This actually happened before the other project.
Yeah. Okay. So you didn't test it. However, they felt like comfortable doing just this new process based on the insights that you found out.
Yeah.
And
yeah, there were fewer complexities. And the other thing was the center that was reading them had already developed not a pre-procedural educational session, but they had developed the protocol for administering the drugs already. So we didn't need to reinvent things.
Okay, so you were able to have like a modular improvement there, basically. So, and in the end, it improved basically that you were able to lower the heart rate in a comfortable way. So pictures could have been taken in a better way, but also in our pre-conversation that you mentioned that the number of canceled scans actually increased. And that is actually a good thing, right?
Yeah, because they were scanning people who weren't at target. And the real solution there is when they're not at target is to cancel the scan and order a different type of test.
Yeah. All right. So then there's a last project, and given the fact that we have a lot of questions, actually, now the question is, should we go to this project quickly and then address those questions?
I'll give a brief overview of it because I actually think it's more interesting than the cardiac radiology project. So the third project we were going to discuss is a project where we use translational simulation, examining the delivery of virtual critical care. So as I mentioned at the beginning of this interview, a lot of care is distributed in Canada across long distances. That means that some small communities are not sufficiently populated to have specialized emergency or critical care physicians there. They may have general practitioners who can provide some support, or in smaller communities, they have specialized nurses who work rather independently. So what we do is we use video conferencing technology combined with a network, a secured network that allows us to deliver critical care remotely. So in this particular project, what we did is we ran several simulations evaluating a wide variety of issues. So how do patients interact with the technology, or how do staff interact with the technology? How is care impacted by it being delivered through teleconferencing? We also looked at like spatial constraints, because we were looking at everything broadly. We were looking at educational issues. And we then did what's called a latent safety analysis. So we looked latent safety threat analysis. So we use something called SEEPS, which is a human factors engineering system that's used to evaluate safety in healthcare. And using that, we post hoc coded, it's an extremely time-consuming task, coded 3 simulations from several different angles using the video that we had. So we had several video cameras in the room. We had video camera at the remote, at the hospital that actually provides the care. So we were able to evaluate all elements of it. So we were able to identify things, for instance.
Yeah, let's talk about examples, right? So because so I imagine you are like providing care for a really, you called it a tyranny of distance, like to a place that is so far away, like 2,000 kilometers away, and you are the specialist, and you are depending on like a remote technology, basically. What were like important aspects to consider? And maybe you can explain this on with an example, and what actually mattered the most, because it might not be the technology in the end.
So we found a few things. We found first, we found that some things were done really well, that staff already performed.
Give us an example, like just one example.
Like onboarding, for instance, they're doing CPR, and the nurses are doing CPR. There's no physician in the room. There's no physician in that town. It's a nursing center, and they need to call an emergency physician at another hospital 800 kilometers away to provide them with guidance on how to resuscitate this patient. So the 3 of them are actively doing CPR on this patient, trying to start an IV. So someone's doing CPR, someone's trying to do an IV, someone's trying to bag the patient. So it's a chaotic environment. So one of the things I was surprised was, I was kind of wondering, like, how long does it take them to actually call for help? And how long, once they call for help, does it take for the physician to actually show up on the screen? And I thought that this was going to be one of the challenges. It wasn't. Like, consistently, they made the phone call at a very appropriate time in the resuscitation, and they onboarded the physician within 1 minute, because the hospital providing the care was well organized in getting the physician to the phone, talking on the phone while the nurse set up the video conferencing system, and they really were like a minute. So that would be an example of something that we found out, oh wow, that works really well. Conversely, an example of where things were a challenge. This is worse if they were just doing it on the phone. Video conferencing is much better than phone, because the physician can see what people are doing. But monitoring in real time, you know, what's the blood pressure, what's the heart rate, that kind of thing, is really essential to physicians trying to give advice on resuscitation. And what ended up happening in the first couple of simulations was the physician would repeatedly interrupt the team to ask them, like, what are the vitals? What is the blood pressure? What is the pulse? And for a team who's already frantically working because they're,
Yeah.
kind of outnumbered by the number of tasks that they have to do, that's disruptive from both a physical task perspective, and it adds to their cognitive load. We tested in the third simulation the use of Zoll, which is not customs in German, but rather just the name of a company that provides monitors. We tested Zoll's product that allows for remote monitoring. So they make a physical monitor, but the monitor can also be observed in real time on the internet. And that eliminated any cognitive load related to that. So, to some degree that might be expected, but you don't know for sure until you test it. Like, will the physician use it?
Yeah.
Is the interface a proper, what does the GUI look like? And we were able to establish that. There were several other things. In the light of time, we can kind of move forward if you like, but those are kind of two examples of one thing that we found that was done really strongly, and another thing where we found the advantage of using a new product.
Yeah, no, that is a good point, that the technology, like with the cameras and that you can see everything, worked very well, and also how to update the emergency physician in your case as well. But then always those follow-up questions in between were more like an obstacle or bothering them, instead of that they just do their job, and finding another way to follow up with those things is a good insight, I would say, right?
Mm-hmm.
So, and that is something which we also had on LinkedIn as a follow-up questions, because this person...
I'm sorry, I missed these.
Yeah. No worries. I was just gathering already questions beforehand, and now I guess we are starting the Q&A, and I will also we will also address the questions in the comment sections now. But because you mentioned it is sometimes a very chaotic process, right? And she asks, most of our design artifacts, blueprints, journey maps were built for a stable, predictable service. Do they actually work for something as a chaotic, fast-changing as a transfusion, or do we need different tools? So in this case, also like to try to take care of a patient that is far away, and you give instructions, and there's also an emergency to it, is or could be also a very chaotic process in the end. What do you think about this question?
I think it's a great question. I think I would look at it twofold. There's one thing I say about emergency physicians. I think good emergency or critical care physicians, they bring calm and order to chaotic environments. Contrary to what you might see at times on the Pit or ER, the shows, the idea is that physician is adding to the calm of the environment, not adding to the chaos of the environment. And there's two ways to do that. One is, I do think that protocols work very well for a wide variety of emergencies. Like, let's take anaphylaxis, like a deadly allergic reaction, potentially deadly allergic reaction. A very clear protocol. It's not the most complicated thing to treat in most cases. It just needs to be treated immediately, or it's life-threatening. So for that kind of thing, a protocol is very useful. And I think any physician will agree that textbook medicine, as we call it, like textbook medicine can be a cookbook. I misspoke. Cookbook medicine is not a good way to practice, because each patient and scenario is different. So there's some degree of uniqueness to each situation. So I think, sure, there are some limitations in that you can build a protocol and then something comes up that isn't effective. The hope is that there's enough experience in the room to work around what might be problematic at the time. But by and large, hospitals are headed more and more towards, like, for instance, order sets of orders for common things. So I think actually the same kind of things like journey mapping and using service blueprints, they're very applicable to the healthcare environment.
Could you repeat the last sentence again?
I think very much the same type of things like journey mapping and service blueprints are very applicable to the healthcare environment. The tools aren't necessarily unique. The application of them may be a bit different.
Yeah, okay. Thank you for sharing. I would like to read out something which here a user in the chat wrote. So I previously worked on a Mayo Clinic Nursing Award project where our team redesigned the nurse nomination process. The biggest challenge we were encountered was that many stakeholders didn't understand the value of service design. At the time, our final deliverable ended up being a well-designed trophy rather than a redesigned nomination process. Looking back, I wonder how we could have engaged our stakeholders differently to help them see the value of improving the entire service, not just the final artifact.
I'm just laughing a little bit because I mentioned the Mayo Clinic amongst like the 4 different hospitals there as having service designers. So that's
interesting.
That's
yeah.
kind of funny. Selling value. I've been to enough UX and service design talks now, and then had enough conversations with my partner. I don't know what the trick is to selling value of it. I see the value in it because of my repeated exposure to it, but perhaps it's something that is better understood by someone who works in the design environment. From my standpoint, I mean, I'll circle back to the same thing. You need good leadership, and you need a champion who understands the value of good service design. And if you don't have that on your team, it may be exceedingly hard. Like I empathize with the person posting this comment. If they really don't see the value of it, that can be a challenge. And certainly, giving out a nursing award is a complicated process, because I just think there's so many amazing nurses. So I like starting on that process of trying to figure out who you're going to give an award to has got to be complicated.
Yeah, but do you also think there's money I mean the obstacle of money? Oh, if we now go more into this will only takes more effort, more money, more investment, and that's why we actually don't want to take a look into this. Is that maybe also a factor?
That's one of the problems, but there's a group out of, I think it's called Health Quality Alberta. I think they're based in Calgary in Alberta in Canada. They've done return on investment studies related to things like translational simulation. And at least in the context of building and prototyping physical spaces, they were actually specifically, they were looking at the value of prototyping spaces before construction, because depending on the complexity of the building that you're doing, you could be looking at tens, hundreds, or even, I think in the case of operating room project in Vancouver, over $1 million for just prototyping the space. But what they ended up showing is that you get return on investment because you save money later down the road in this particular situation by not needing to do renovations. So renovations, safety, all of these other problems. The problem is the cost savings is down the road a bit. It's not immediate. It requires some capital investment now. But I think more and more we're seeing, certainly in Canada, the value of doing these types of prototyping projects, for instance, as part of capital planning. And I mentioned this University of Ottawa Hospital project earlier. Obviously, they've identified that they're going to get the return on their investment if they're going to build out 12 rooms.
Yeah, I think this is a good point here, because you basically use the simulation that is known in education in the healthcare system and use it as reasoning to take a deeper look into things. And this is actually also something that I have done. For instance, I also worked with clients who didn't believe in interviewing people, doing stakeholder interviews, user interviews. No, we just want to build a product, maybe test it, and that's it. So they were already open to test it. So how to find basically the back door to implement insights and interview questions more in a testing environment. And that is your door, basically. So I would say, just also from my perspective, because I'm also working as a consultant, find ways, methods that they are already familiar with, and find like back doors where you can infuse those additional methods that bring ultimate value to it. And then they will say, oh, this is interesting. Okay. And then you can also this return of investment report show, because if you talk money, that is always an add-on and a good pitch as well. And I think those could be like first approaches to do that, really using the vocabulary of the industry and not like lecturing them, oh, I'm a designer, I know those methods, now you have to use those methods, because then I think you will face rejection right away.
Yeah, I think speaking their language is one way to do that. I mean, that's what I kind of view myself in part as a design clinician. My role is in part to act as an in-between in some ways between designers and clinicians, because there is a mismatch between language sometimes. But I think don't undersell yourself either as a designer and completely try and adopt the methods that they seek to use, because it may be also underselling what you offer. So
I mean, I completely understand. And in the end, we extend and expand the horizon with this as well, right? But you always need to
start from that position.
But you need to find like a door to get in. And I think then it's way easier to expand like the tools that you will use, the methods, and then you also constantly show value. And keep also the financial part in mind, because in healthcare, finances matters as well as in many other industries as well. There's like also a question from Sudeshna from India, and I think this also keeps or is connected to what we just discussed. What does it mean to build service design capacity into healthcare as a core capability? What areas can we contribute or pitch to? And I think we already covered a lot of it, but maybe you have something additional to say?
I think we have covered a lot of it. I'll just say a few areas. I think chronic disease management is a big area that we have not discussed because it's not a big part of what I do. But I think there's a lot of opportunity in chronic disease management, diabetes, that kind of thing that I'm thinking about in terms of working with clinics that are trying to initiate lifestyle changes and that kind of thing. So that's one thing we haven't spoken about. We've talked about delivery of particular products within the hospital, transportation needs within the hospital. We've talked about physical architectural considerations. So there's several areas, but I think the one we hadn't touched on was looking at how to assist patients with behavioral change and how to work with chronic disease clinics in offering services.
All right, thank you so much. I actually have a few fire questions for you.
Okay, let's do it.
Just very quickly, one answer. Service design in hospitals, luxury or necessity?
Necessity.
Biggest bottleneck, Frontstage or Backstage?
Backstage.
Then in situ simulation or the lab?
In situ.
Emergency medicine, breadth or depth?
Breadth.
A unified global emergency system, dream or delusion?
Delusion.
All right, this might be a follow-up topic. Who teaches a clinician more, a patient or a designer?
Oh, sorry, patient.
Yeah, I mean, I think we as designer also learn from the user, the patient, the most. The thing most hospitals underinvest in one word.
That may depend on the country. I'll speak from my perspective. Innovation.
Innovation, all right. And one word for the hospital of the future.
Patient-centered. Sorry, it's 2. Put a dash in
Patient
there.
center. All right.
Patient-centered.
Okay, great. I have one last question. So, for the people who are watching this and maybe who also work in hospitals, and has never heard of service design before, what's the one thing they could do on Monday? Or even people who are working in healthcare and want to improve things. What is one thing they could do right away?
I mean, the first thing that comes to mind is I'm open to discussions, so feel free to get in touch. If there was one other thing that they could do, you're talking about healthcare workers, not designers, correct?
Yes, I mean, yeah, more healthcare workers, but you can. I think
just
yeah.
Watch some YouTube videos. Learn what service design is. Find out. Go on LinkedIn. Follow Service Design Network. See what designers do.
Okay, great. Yeah, or just be open to a creative person and who suggests something and just try it out. Be open for experimentation, I would say. I think a lot of people are hesitant about this, and I think this is the one thing where your eyes could open up if you see, oh, that's interesting. That's a new insight.
You made a very good point there. Healthcare tends to be a slower moving industry because of safety concerns. And that's one of the reasons why it's slow to innovate. But what I would argue is that actually, if you involve designers in care, you're more likely to be involved in iteration. You're more likely to be involved in making sure you've seen all aspects of a given problem. And you're less likely to have problems with safety and outcomes. So the reality is, while it seems like something innovative and perhaps intimidating, it's quite the opposite.
Yeah, that is a very good point. And I was also working in life science healthcare projects, and I know that especially doctors need to follow protocols and safety requirements, and that those people are actually becoming open for experimentation or simulation. In your case, for instance, really improves in the end actually the better care. Thank you so much. We are a little bit over time, but I would say that is okay. It was very insightful and an inspiring journey how you become basically a design clinician. And a big thank you to our community for joining and engaging live. A shout out to all innovators driving transformation and building beyond boundaries. And don't forget to like, share, and follow SDN on the socials, and also there's a conference coming up in October, so tickets are available. Maybe you would like to get one and learn more about service design. And until next episode, see you there.